Effect of reducing abdominal compression during prone-CT colonography on standing colon rotation that occurs due to spine-to-prone positional change. The object mobility and positional change is one of the key characteristics of pseudo-lesion. Mobility of colonic segment, not the lesion itself, can mimic the lesion mobility, typical segment colon, transverse colon, and secant. In addition, recent studies show that ascending colon, which is generally known to be immobile segment, may also rotate on prone position due to abdominal compression. So the purpose of this study was to determine if the maneuver to decrease abdominal compression can prevent ascending colon rotation on prone CTC. Material methods. Here's details of CTC technique. After standard cathartic preparation, free catheterizing with an iodine and carbon dioxide insufflation, we obtain both standard spinal prone CT scan. Above the mentioned maneuver was applied by placing a cushion block in a wedge-like fashion under the chest and pelvis on prone position. Eligibility criteria is follows. Presence of colonoscopy proves C-side polyps which are larger than 6 mm in the middle ascending colon, which is optimally distended on both spinal prone CT scan. And absence of other disease that probably cause colon adhesion, such as breast cancer or inflammation. We reviewed 12 18 CTC exams spanning 20 months at Asan Medical Center. Among them, we investigate 24 polyps in the range of 6 to 16 mm of lesion diameter. And we carefully identify the same polyp on each position by tracing down 3 tinea coliform ileocecal area. We measure the radial location change of polyp and 3-body indices. From now on, I'm going to talk about what they were and how we measured them in our study. First of all, we developed the radial coordinate system to designate polyp radial location of 2D CTC. On the spine CT scan, straight line A was drawn to connect the lateral tips of bilateral transverse process of lumbar vertebra that was closest to polyp of interest. Line A was referenced horizontal line which is unaffected by rotation of torso. And then line B, parallel to line A, was drawn to pass through the center of ascending colon. And then line C, perpendicular to line B, was drawn to pass through the center of ascending colon again. Subsequently, 4 points where these line B and C met the colon wall were designated 0, 90, 180, and 270 in the clockwise. You can see polyp at dorsal medial side of ascending colon to the CTC, 3D luminant imaging, and colonoscopy. So, radial location of polyp according to the coordinate system was 119 on spine CT scan. We repeated the same procedure on prone CT scan. Let's check the radial location change of polyp with this example. On your left spine CT scan, radial location of polyp was 243. On your right front CT scan, that was 226. So radial location change of polyp during positional change from spine to prone position was 17, which is external rotation. We repeated the same procedures for all 24 polyps. As for the body indices, we first measured the abdominal compression as the change in abdominal thickness from anterior abdominal wall to the lumbar spine. So the greater value means greater abdominal compression on prone CTC. Second, ascending colonic displacement as distance of ascending colonic movement. It was acquired by measuring change in vertical distance from center of ascending colon to the lumbar spine. So the greater value means greater posterior displacement on ascending colon on prone CTC. Last, we measured the angle between abdominal aorta and tremain trunk of SMA on both spine and prone CT scan. SMA shifts angle difference during positional change from prone to spine position and represented degree of anterior shift of small bowel mesentery on prone position. So greater value means greater anterior shift of small bowel mesentery on prone CTC. We figure out the correlation between radial location change of polyp and 3-body indices using Spearman correlation analysis. And we took known observed variability from previous study, and that was approximately 10 degrees. Switching gear to the result. The mean value of abdominal compression was minus 12.8%, which meant absence of abdominal compression. And now seeing the result between group with and with the cushion block. They revealed that lower median value of external rotation in the group with the cushion block. However, this histogram showed there was still a trend of external rotation even with the maneuver. More than 50% polyps showed external rotation beyond observed variability, and 13 polyps showed large degree of external rotation. What happened to the polyps even without abdominal compression? This table may give you the answer to the question. Look at the semi-shift ascending colonic displacement. They show positive and significant correlation with radial location change of polyps. So, anterior shift of small bowel mesentery and posterior displacement of standing colon may cause external rotation of standing colon on prone CTC. Let me show you an example with large degree of external rotation, which is 61. Look at the much of small bowel mesentery indicate wide errors in prone position compared with that of on spine position. These are occupied in abdominal spaces and to the medial to midline standing colon according to the gravity once the abdominal compression was gone. They probably push a standing colon posteriorly with a certain degree and made a standing colon rotate externally. Here is conclusion. Ascending colonic rotation that occurs due to spine-to-prone positional change in CTC was not eliminated by removing abdominal compression in prone position. And the vast majority of patients still show the external rotation of a standing colon. So it is important to know this phenomenon of standing colon rotation so as not to fall into the interpretive pitfall.